Okay, welcome back to Diabetic Foot Files. This is part two of skin substitutes. So, every graft, every indication, and every mistake. So, skin grafts are not interchangeable. Skin grafts are not magic and they're not wound care shortcuts. Okay, skin grafts are biological instructions. And if you give the wrong instructions to the wrong wound, you still will fail. So, today we're naming names. So, this episode is not sponsored. Like I said, make common sense common. Okay, this episode is not like brand loyalty. This episode is about biology. Okay. And so that people are aware, know the names of which. I think you're supposed to know these for boards, even. So, yeah, let's get down to it. Okay. So, let's get back to the foundation of it because we did that in part one. So, what did we say that skin substitutes actually do? All skin substitutes function by interrupting the chronic wound pathology. Specifically, remember, what does a chronic diabetic wound pathology have? Elevated MMPs, which break down and degrade the extracellular matrix, suppressed TIMPs, TIMP. Those are the ones that regulate the MMPs are supposed to like, hey, MMPs, you're getting a little too carried away, eating too much of the extracellular matrix, right? But those are suppressed, okay? The fibroblasts are silenced, okay? The macrophage 1 are dominant. Remember, macrophage 2 were needed to get wound out of the inflammatory phase. There's hypoxia in a chronic diabetic ulcer and the extracellular matrix degradation, but we already talked about that. And how do skin substitutes work? They work by modulating the protease, which break down the skin matrix. Substitutes also help by extracellular matrix replacement. Skin substitutes work by cell signaling. They have this paracrine effect. That means signal side by side signaling, right? Or nearby. Angiogenic stimulation and mechanical coverage of exposed structures. So if you don't know what phase the wound healing you are treating, you're just guessing. And we don't like that. We don't like it. Okay? So let's do a trademark product breakdown. Like I said, make common sense comment. I'm not like loyal to anything, like any of these products or whatever. Everybody needs to know how to use, how to work, which one to contact to help a patient get out of that phase of a chronic wound. Okay? So category one, we're going to talk about bioengineered cellular skin substitutes. So Apligraf. Apligraf is made from living neonatal fibroblasts and keratinocytes. It has bovine type 1 collagen matrix. Remember, we need type 1 for the remodeling phase, right? Because remember, in the proliferative phase, collagen type 3 is, laid down on the layer. But in remodeling type 1, it moves from collagen type 1, type 3. Collagen type 3 is replaced with collagen type 1, which we want. Okay, that's the more stronger one. So Apligraf has living neonatal fibroblasts and keratinocytes. It uses bovine type 1 collagen matrix. The biochemical action of it has an active secretion of PDGF, VEG, VEGF, what I call TGF beta, and it restores the dermal epidermal signaling, and it suppresses inflammatory cytokines. FDA approved in the late 1990s, okay, and one of the few true FDA approved skin substitutes. What is Apligraf best for? Best for neuropathic diabetic foot ulcers, a nice, clean, granulated wound, or a wound that has been stalled for more than 4 weeks. So, what is the inclusion criteria? The patient has to have adequate perfusion at ABI of greater of zero point 0.7, okay? No infection present, offloading in place, and a hemoglobin A1C that is reasonably controlled. What are the exclusion criteria for Apligraf? Ischemic ulcers, active infection, heavy exudate, and poor compliance. Okay, so you literally have to evaluate the patient. I remember doctors saying that, you know, he actually evaluates the patient for surgery. Like, yeah, the patient may want you to do the surgery, but do you want to do surgery on this patient? So that's also when it comes to skin grafts. Like, do you want to put a skin graft on this patient? Are they compliant? Are they going to go MIA for the next 5 weeks and you don't see them? Because you're the only one who has to change this skin graft, right? Are they going to keep walking on it? Things like that, okay? But application of Apligraf is a weekly application. Maximum is 5 applications. Must be debrided. The wound must be debrided, and it must be applied immediately after debridement. You want that nice, healthy, red bleeding wound base, okay? And Apligraf usually fails when clinicians treat it like a dressing instead of a living tissue, okay? Now, next one, Dermagraft. Dermagraft composition is living fibroblasts on a polylactin mesh. Okay, biomechanical biochemical action of it. It produces extracellular matrix proteins, and it stimulates the host fibroblast migration. Best for chronic diabetic foot ulcers with granulation deficits. It fails when there is excessive inflammation and poor offloading. Now let's get to category two, human dermal matrices, like cadavers, okay? So alloderm. Alloderm composition is an acellular human dermis. The biochemical action of alloderm is it has a structural collagen scaffold and host cell repopulation. So it's best for deep diabetic foot ulcers, also when there's tendons exposed or bone exposure, and post-surgical wounds. The exclusion criteria is if there's an infection present or poor vascularity. Graft jacket. Graft jacket composition. Graft jacket is made from an acellular human dermis as well. The clinical strength of graft jacket is it has high tensile strength, which we want for durability, right? And excellent for exposed structures, like I said, tendons, bone, things like that. Next category, placental slash amniotic products. Okay. I think this might be one of the most used categories, possibly. I love EpiFix. Okay. I watched a lecture on EpiFix. It performs miracles, in my opinion. Okay. But like I said, each one is different. Each one is for the right wound. Okay. It's like a Cinderella, right? Cinderella skin grafts, right? So, EpiFix composition is dehydrated human amnion chorion membrane. The biochemical action of EpiFix is it has anti-inflammatory cytokines. It regulates TNF alpha and it promotes epithelial migration. That's what we want. So it's best for superficial diabetic foot ulcers, painful ulcers, great for painful ulcers, and early chronic wounds. Inclusion criteria like what things that allow you to put it on is also if there's no infection and minimal drainage. Overuse warning is repeated use on it on a ischemic wound is actually clinical malpractice. Okay? Graphics. Graphics is composed of cryopreserved placental membrane and it retains viable cells. The biochemical action of graphics is active cell signaling and angiogenesis promotion. That's what we want. Graphics is best for refractory diabetic foot ulcers and high risk patients. And then AngioBand, AngioFix, Clarix, New Shield, and Bio Dryflex. Point of this, the processing method matters more than the brand. Okay? Xenografts. What are xenografts? Like animal derived grafts, right? Integra. Me some Integra. Integra dermal regeneration template. Composition of Integra is bovine collagen plus shark choriodrontin. Okay, choriodrontin sulfate. Okay, forgive me for pronouncing wrong. The biochemical action of that is it creates a neodermis, which is amazing. And it has this two-stage healing process. We did an Integra publication sometime in residency. It works very well on wound secondary to tumor removal, like a verruca tumor removal. It works very well. The patient able to keep his toe. And it's best for large deficits and post-amputation wounds and exposed bone, and tendon. Exclusion criteria for that is an active infection. No active infection should be present and you're applying that. Prime matrix. Prime matrix is composed and made from fetal bovine dermis. Okay. And clinical use of that is the clinical use for that is for high tensile support and it can be used for traumatic or surgical wounds. Now, synthetic slash hybrid matrices, skin substitute. OASIS wound matrix. OASIS wound matrix composition is made from porcine small intestinal submucosa. So biochemical action of OASIS is extracellular matrix signaling and cellular migration. That's for shallow diabetic foot ulcers and early intervention wounds. Okay. So part two, we're on application protocols, which are very, very important. So what are the universal rules of application of a skin substitute for anything, right? Sharp debridement to bleeding tissue. That's what we want. We want to see it. So nobody freaks out when you see the tissue bleeding. Oh, 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 they may move. Please, I majority of my patients have learned the more they bleed, the better it looks, like the next week almost closed, because we removed the devitalized tissue, we woken the wound, it's fresh, it's new, and it heals so much better. But you need sharp debridement to bleeding tissue. Next, infection control. Three, vascular status is optimized. You want to make sure of that. Offloading is documented. You can't just put it on a patient that just keeps walking on it or has like a flimsy post-surgical shoe or post-surgical shoe that they've been overusing for the past year and it's like flimsy, doesn't offload at all. Stay off of it. And wound measurements are documented. If you skip these steps, you're committing documentation fraud pretty much. So sharp debridement to bleeding tissue, infection control, vascular status optimized, offloading documented, and wound measuring documented. Okay? After application, you have to use a non-adherent contact layer like Adaptic, okay? Me like Adaptic, and moisture balance, but that's kind of also part of the non-adherent thing because it has like a little bit of that petroleum in it. Strict offloading and no unnecessary dressing changes. Okay? So, inclusion versus exclusion master table, okay? So, inclusion, like the reason why is this diabetic foot ulcer a good candidate for a skin substitute? And is this diabetic ulcer not a good candidate for a skin substitute? Okay. So, inclusion criteria for skin substitute, a diabetic foot ulcer that is more than 4 weeks old. Okay. Like standard care did not work. Plateaued healing, clean wound bed, and perfuse limb. Okay. Like a limb that has blood flow. Exclusion criteria, infection, ischemia, necrosis, non-compliance. Okay, it literally is an exclusion criteria. That's why doctors should know their patients. Know your patients, okay? Get to know them, know their goals, know their lifestyle, know what are their expectations, what are the demands that they have on life. Like if they're very busy, they can't leave work, like things like that, okay? And when to stop. If you don't see improvement with the skin substitute after like 2 or 3 applications, you should stop. Okay. Failure signals no reduction, like failure like with the skin substitute shows like there's no reduction in size. There's persistent inflammation. There is increased drainage and recurrent slough. Okay. And controversies when it comes to skin substitute, like I'm not gonna like filter this, overgrafting, like using it more than you should. Profit driven selection, let's not do that, okay? We're doctors, we're clinicians, we're healers, we're not supposed to you can't be bought, you shouldn't be bought. Ignoring the biomechanics of the wound, okay? That's why biomechanical evaluation is a huge deal when it comes to any wound or ulcer. Replacement surgery with grafts, replacing the surgery with grafts. Like if the patient, I guess, has osteomyelitis, the wound's not healing because of the osteomyelitis, and you're just trying to put a graft over osteomyelitic bone, and the property wound would probably heal way better if you just remove that piece of bone. I'm not saying amputation, but that is a feasible option. So, but you're a clinician, you're able to reason properly and treating codes instead of wounds. Okay. So no skin substitute can override infection, ischemia, or gravity. Okay. So this is part two of skin substitutes. I hope everybody liked that. Skin substitutes don't heal a wound. Remember, clinicians do. These products are tools, not saviors. And hopefully this episode was good for people because that's where growth starts. And growth starts in the heart, right? And like we said, toes tell the truth. And this is Diabetic Foot Files with Dr. G, where wounds always tell the truth. They really do. And hopefully this episode was very helpful if you have a stalled wound and you never thought about possibly doing a graft. Okay? So take care of your feet because they take care of you.